Good morning, good afternoon, and good evening, everyone, from wherever you're joining us, and welcome to today's webinar titled Improving Patient Outcomes, AI-Based Phenotyping for Diagnosis, Treatment, and Clinical Trials, featuring OM1's clinical experts who will explore how artificial intelligence can find phenotypic patterns and unlock insights hidden in real-world data. I'd like to thank the sponsor of today's event, OM1, for making it all possible. I want to take this moment to introduce the panelists participating in today's session. Dr. Gary Curran is Chief Medical Officer of Research at OM1. He is practicing nephrologist in Boston and has published widely on the epidemiology of many medical conditions, including cardiovascular disease, hypertension, kidney stones, gout, and others. Our next speaker is Dr. Carl Marcy, the Chief Psychiatrist and Managing Director of Mental Health and Neuroscience at OM1. Next up, we have Dr. Stefan Weiss, who is the Managing Director of Dermatology at OM1. He is a board-certified dermatologist, served on several national medical advisory committees, and has published widely on psoriasis and atopic dermatitis. Our fourth and final speaker, who is also our moderator for today, is Dr. Joseph Sabinski, Managing Director of AI and Personalized Medicine at OM1. He specializes in applications of advanced analytics to real-world data in healthcare and life science contexts. And now, without any further delay, I'm pleased to welcome Joseph to join me. Okay, take it away whenever you're ready.
Great. Thank you, Sydney, and thank you everyone for joining us this afternoon as we talk about AI-based digital phenotyping for all sorts of useful applications in improving patient outcomes. So just to give you a little bit of an orientation towards what we're going to be discussing, I will start off by giving a very brief introduction to AI-based phenotyping, OM1's phenome approach to phenotyping, and why this is a useful useful application of AI technology. We're going to spend most of our time today highlighting 3 case studies in 3 clinical areas in collaboration with my 3 clinician colleagues who are also on the webinar. We'll walk through those in detail. And then we'll conclude for a couple minutes and try to leave some time at the end for Q&A. We won't be answering questions during the webinar itself, but if you do think of them as we progress, feel free to drop them in the Q&A chat function so that we can address them at the end. So to dive in, I am guessing most folks in the audience are all too familiar with this sort of paradoxical challenge of real-world data and real-world evidence that most of us have probably pulled some hair out about over the years. And it's this idea that we know that there exist insights hidden within large data sets that can tell us something meaningful about patients with particular characteristics, but we don't know how to get those insights out of data sets at scale. And this is sort of like, for example, we observe a patient in a data set who was diagnosed with a disease at a particular point in time. And then we say, let's roll back the clock. Let's go back 6 months, 2 years, whatever it may be, and let's see what was going on with that patient in advance of their diagnosis. We can learn from that process, and we can learn what factors in the patient's history are associated with the outcome that eventually ended up happening to them, in this case, their diagnosis. When we sort of do that careful patient-by-patient review, we can see how these patterns manifest over time. But the challenge has been trying to do that at scale across many different patient records, across many different dimensions of data in a way that's analytically rigorous, repeatable, and that we can then turn around and use for something. So that's kind of the setup, and I think that anyone who's worked with data to answer these real-world questions has wrestled with this. The solution that I think is truly one of the best applications of AI in healthcare today is AI-based phenotyping, and it's a way of solving this problem. Specifically, AI-based phenotyping starts with a group of patients that have a characteristic of interest, like being diagnosed with a certain disease, and then uses AI technology to go through those patients' records and identify these patterns that those patients share in common that led up to that event that we're interested in, and then importantly synthesizes and combines those patterns in a statistically meaningful way to develop an AI phenotype, or almost like a phenotypic fingerprint for what those patients look like. So we have a set of patterns that those patients share that's associated with their outcome, and that helps distinguish those patients from others that we might be looking at in comparison. This is really powerful because of a number of reasons. First of all, AI is very good at pattern recognition. Anyone who has played around with some of the most recent and most fun AI tools knows, I think by experience, that these are running on AI's ability to recognize and utilize patterns. So just finding patterns at scale is definitely something AI can help out a lot with. Importantly, AI is also quite good when calibrated well at balancing different pieces of information. So a lot of times when we're looking at patients, we know that there may be different factors, diagnoses they've had in the past, treatments they've received, providers they've seen. All of these may be clues to what's going on with them. But we don't always have a good way of integrating those clues together and saying, sort of, if we put all the evidence together, what is this patient's risk, for example, and how does it compare to that patient's risk? That kind of weighting and balancing and synthesis is also something that AI is very good at. And then finally, we're all familiar with sort of the hypothesis testing process, right? Where we say, we think that, a patient who might begin manifesting this set of symptoms is more likely to reach this diagnosis 12 months later. Let's go look at a data set and test that hypothesis. That's great and very useful from a research perspective, but it requires us to presuppose or to think about that hypothesis in advance. And we don't always know what we don't know. We don't know which hypotheses have not occurred to us that we haven't gotten to test. AI is very good at hypothesis generation, and AI-based phenotyping is able to say, of all of those hypotheses that could exist, of all the potential patterns that could be in the data, here's the ones that show up as the most meaningful because they're most associated with the outcome we care about. So that's why this phenotyping approach that uses AI is very good at solving that problem of identifying, kind of pulling out patterns from large data sets and then synthesizing them into something discrete that we can use to study patients of interest more closely. This is sort of a theoretical concept until you actually come up with the technology that's needed to make it real. This is what we've been spending quite a bit of time on at OM1. We've developed our PhenOM platform to do exactly this. And PhenOM takes the large real-world data sets that we work with, and we're lucky enough to have access to at OM1, and does this process I've just described. And we're going to talk through the case examples in just a minute, but in every instance, you can sort of hear echoing that we're using the same procedure because PhenOM is a single technology, almost like a single test that you can ask multiple questions of. First step in the test is always tell me which patients you're looking for, which kind of patients you're looking for. So that could be patients that share a diagnosis, could be patients who all experienced, a catastrophic outcome like a stroke or something like that, could be patients who providers have labeled in a certain way. Whatever way we have of defining a group of patients, that's a good enough place to start. Then PhenOM will extract those patterns I was describing, put those patterns together into this digital phenotypic fingerprint. And then we can do two things with that fingerprint that are really important. The first one is we can study it. We can look at the information that went into it. So, procedures the patient has had, lab tests they've undergone, any of that kind of signaling that PhenOM identified as associated with our outcome, we can study in greater detail. And then we can also deploy these phenotypic signatures to go look for patients in the real world. Because now we sort of know what somebody looks like in a data sense. And so we can take that fingerprint, we can put it, apply it to other data sets, we can put it in real world healthcare deployment contexts like in EHRs and so on. And in each instance, that deployment is just saying, we know what this set of patterns looks like. Let's look for other people who look like that set of patterns. So it works at extracting the patterns, and then it's useful because it can be deployed. And just to flash this in front of you, we won't linger in the details of this text because we'll go into some of these through our case studies. But just to give a flavor of the applications that we can achieve with digital phenotyping, they're listed at a high level on the left-hand side. These are all areas that we've applied or are applying PhenOM to right now. Diagnostic insights, certainly concerned with this notion of improving diagnosis, including when you have patients who are misdiagnosed. Treatment insights, who might make sense in terms of benefit from a particular treatment they're not receiving. Risk is almost the other side of that coin, who's at elevated risk for a catastrophic outcome or lack of response. Utilization insights, who's at risk of needing a lot more resources in the future. And then finally, using this notion of digital phenotypic profiling to help us accelerate clinical trials and clinical trial enrollment by matching the right profile to the right trial. That's a very I think, exciting application of the technology, and one that we'll talk more about in just a minute. So with that very quick introduction, I'm going to move on right into our first case study, which is one of these diagnostic cases where we've used phenome and digital phenotyping to enhance diagnostic screening in the area of abdominal aortic aneurysms. And to give us the clinical introduction to the topic, I'm going to turn the mic over to my colleague, Dr. Curran.
Thanks, Joe. Clinically, there's many conditions that we worry about a lot, but aren't always able to detect because they're asymptomatic until a big problem occurs. And so we want to just show you the example of abdominal aortic aneurysm. We refer to it often as AAA. But let me first tell you a little bit about the aorta. If you haven't done anatomy in a while, it's the largest blood vessel. It goes directly from the heart, carries the blood to all the different arteries that then feed the smaller parts of the body. An aneurysm is when a blood vessel enlarges. So in this case, an aortic aneurysm would be an enlargement of a certain segment of the aorta. And the challenge with aneurysms is that they can either grow to the point eventually they could burst, which can be catastrophic, or sometimes they can have a tear in part of the vessel. We call that a dissection, also can cause very serious medical complications. If we know about these in advance, there's lots of things that we can do. Some are non-invasive, some are somewhat invasive, but early detection allows us to repair and avoid the morbidity and mortality. So there's a number of risk factors for AAA. So before you all start worrying about your aortic aneurysm, fortunately, they're not that common, but again, we want to detect them. If you have a history of smoking, older age, male sex, a family history, and then atherosclerotic vascular disease in other parts, not just the aorta, those are all associated with the high risk we're having in AAA. And there's also additional risk factors, hypertension. Again, almost 80% of the population eventually gets hypertension, so that's not a good distinguishing factor, but high lipids, a white race, and then there's certain inherited connective tissue disorders such as Marfan's that put people at higher risk. But there's huge underdiagnosis, as Joe was mentioning. A number of conditions, and AAA is definitely one of them. It's way underdiagnosed in the United States, and then of course that leads to the complications. There are guidelines from the USPSTF that recommend a one-time ultrasound, so just really a non-invasive screening. But currently the guidelines state this is just for male patients, only 65 to 75 with a history of smoking. So obviously a huge amount of the population is being left out, and those other groups in the population often will have a AAA that isn't even being screened for. So the most recent screening guidelines were about 4 years ago. They made some minor adjustments, but it still hasn't been expanded broadly. And partly that is because fortunately it is rare, and we don't want to do too much screening, pick up incidental findings. And really though, the cost benefit analysis that this task force used for making these decisions, there's really limited information. Just last year in circulation, the American College of Cardiology and the American Heart Association developed guidelines together for the diagnosis of AAA. They've actually expanded their recommendations beyond what was in the US task force that I previously showed you. Not going to go through all the steps here, except to show you that there are some reasons why maybe you'd want to consider, is the term that they use, screening in someone that's less than 65. And again, if they have multiple risk factors. So again, trying to enhance these groups, similar to what Joe was talking before. How do we select those that are more likely to have the condition? If you're above 65, it's not just men, it's actually women as well. So for example, with family history, so these aren't in the current other guidelines that I mentioned. And it's not, or they say it's reasonable to screen in women who have smoked because the prevalence in women is just a little bit lower in men. And then for those that are more than 75, if they've already been screened once, then there's no reason to keep screening. But you can see there's a much larger group. But when we think about screening, we really want to try to identify those people that are at highest risk. Because right now in the US, the proportion of people that are being screened that even meet the current guidelines, it's ranging from maybe up to 20%, but that's optimistic. And most of the time, it's probably closer to less than 1%. So we're not even screening the people that are at higher risk. As we've mentioned, it's often asymptomatic before there's a rupture again. So screening is really critical, important. The diagnosis is really straightforward. The ultrasounds are available almost everywhere in the healthcare system in the US, but it does require imaging. So our physical exam is not sufficient to be able to identify these. And as we've mentioned, the screening criteria are just a little too broad to say all men who've maybe smoked at some time. in order to maximize our resources, we really would like to identify those people that are at high risk. And even if they meet the guidelines, to make sure that we focus our energies to make sure those people get screened. So Joe, do you want to tell about how we're solving this?
Yes, I will. But before I do that, I just want to reinforce a point you just made, Gary. I think, some of these screening guidelines, unfortunately, they're almost like, I think of them as anti-Goldilocks problems, right? They're not the, not too warm, not too cold, but just right. They're like the opposite of that. They're too broad, as you pointed out, to say, very precisely, these are the people who should get screened and others don't need to worry about it. But at the same time, they're insufficient to capture anywhere near all of the cases, even if we had perfect screening. And as we know, and as you pointed out, adherence to these guidelines is nowhere near what we would like it to be. And there's certainly the example from other countries that have other ways of getting people to get screened that have, much, much, much greater adherence to guidelines and much greater diagnosis. So what do we do with digital phenotyping to fix all this? That's the point. It's kind of, what I was setting up when I gave the introduction to the technology. We started out in our work by saying, let's look for, first of all, patients who have a diagnosis, because that's a pretty safe class to begin studying. Because of the size of our data sets, we were able to come up with 500,000 such patients, including 10,000 or so patients who have a history of ruptured AAA, sort of the cases with the worst outcome. And then we asked Phenome to develop a digital phenotype corresponding to those patients, to say what was true about them, before they reached their diagnosis that distinguished them from others. When we did that sort of on the computer, we got quite good performance of this phenotype in identifying these patients when we tested it. But we've also worked on beginning to put this technology into the clinic. And we've seen some interesting results. So one of those that we sort of project from our testing work is that we can get really dramatic increases in what I call screening yield. So this is sort of like for every ultrasound that you do in this case, what's your chances of actually detecting an aneurysm? We always want, in a perfect world, to only scan people who are going to test positive, right? We are seeing detection at about 5 times better than what would be expected of the baseline rate, which is not a small gain. In other words, it's much more worthwhile for someone who's identified through this mechanism to come in for a scan, because they're much, much, much likelier to actually test positive. Importantly, personalization of this sort has also seemed to lead to an increase in patient response when the patients are reached out to, right? Because we're not just saying, if you're a man who just hit the age of 65 and you smoked some cigarettes 30 years ago, you should probably come in. We're saying you specifically, based on all of this patterning information in your history, are at elevated risk and really should get screened. And that helps more people who are at greater risk to come in. And then finally, I'm glad you touched on the most updated guidelines and this notion that there do exist patients outside of what might be thought of as the most classic risk group here, men over the age of 65 with a smoking history, who also may have AAA, but we really don't have a good way at all of getting at who within that broad group of other patients is at elevated risk. That's another place where this kind of application would be great. For example, if we said, let's look only at women in our real world data set who have a history of AAA, let's isolate the phenotypic fingerprint of those patients and then go see who looks like that fingerprint. That could really help there. So Gary, the question I always like to think about, and I know we've discussed a lot on this topic, is from the clinician's viewpoint. All of this sounds great. We're seeing some great results in clinic. Do you think that this kind of tool with these kinds of results is something that could actually help move the needle in clinical practice?
Yeah, I really do, Joe. For all of us who go to the primary care providers, they're getting hammered, like screen for diabetes, screen for this, screen for that. And, there's just not enough time in each appointment or for each provider to be carefully considering each of our individual risk factors to be able to say, oh, you have a 1 in 100 chance and that some group recommends screening, but another group doesn't. Like, I don't know what to do. But if you can start to move that needle and say, okay, Gary, your risk isn't 1 in 100. It's actually 5 in 100 or 10 and 100, and explain, pretty quickly how risky it is to have a AAA, how easy it is to screen, how basically risk-free it is. I think it will make a huge difference in helping the providers decide which things they want to help push their patients towards.
Great. All right. Well, thank you, Gary. And we could do an entire webinar just on this topic, as we know, which is going to be the theme throughout our remaining 2 case studies. But just to make sure we pack it all into the time we have, I'm going to move on now to our second case study, which is a different application of the same phenome technology, the same digital phenotyping principle. But rather than being in the area of diagnosis, we're now going to talk about the concept of treatment response, and in particular focusing on patients with varying levels of response in depression. And to give us the clinical introduction and insight here, I'm now going to turn over the mic to my colleague, Dr. Marcy.
Thank you, Joe. Moving from the aorta to the brain, we're going to talk a little bit about treatment-resistant depression. And as you know, just a few weeks ago, we were in San Francisco at the American Psychiatric Association presenting these results to a standing room only crowd. And we talked about why this was such a popular topic. I think in part because we're using AI in mental health, which I think is a trend and one that will continue to grow. But I think secondly, because there's a lot of enthusiasm about new treatments coming for treatment-resistant depression, but some confusion about how to define it. And that's really the core of what this study was about. And one of the things that clinicians are very good at is pattern recognition. One of the panelists quoted Potter Stewart from 1964 as a Supreme Court justice who, when asked what his test for obscenity was, famously said, I'll know it when I see it. I think we're really in a situation in treatment-resistant depression where that may be happening too much. So we decided to apply 3 different definitions to a real-world data set. So this is OM1's premium major depressive disorder data set of over 500,000 patients who qualify, and we have deep clinical data, which means we have clinical notes, pharmacy and medical claims. And the 3 definitions we used are on the screen. The first is what is often referred to as the regulatory definition. This is what the FDA uses. It's sort of a clinically common sense definition of treatment-resistant depression, and one that many academics use, and certainly because the FDA uses it, it's used commonly in clinical trials. And this is the idea that a patient with major depressive disorder has failed 2 or more different antidepressants within a single episode of adequate dose and duration. And so we applied that definition to our data set to generate a cohort. And then we compared that to 2 different definitions. One we called the data-driven definition, which was in the published literature already. And it was based on a gold standard that used patients who had received either ECT, electric convulsive therapy, DBS, deep brain stimulation, or VNS, vagal nerve stimulation. And for those who aren't familiar with interventional psychiatry, ECT, DBS, and VNS are pretty invasive procedures, and really only the sort of sick of the sick get them. So this is a very high bar in terms of treatment resistance. However, using a claims-only data set, the model created a definition that was very broad. And that definition is any 3 antidepressants within a year, or 1 antidepressant plus 1 antipsychotic within a year. And we liked that definition because we thought it would be the easiest to apply to a real-world data set. And then the third definition is the one that you and your team created. And I just want to describe, where we started. And this is unique to OM1 because we have the clinical notes. We actually used text extraction and medical language processing to identify what we refer to as clinician attestation. What does that mean? A psychiatrist actually had to write in the clinical note, patient has treatment-resistant depression or variations of that. And we were very good at identifying whether it was an affirmation, meaning patient has treatment-resistant depression, versus a negation, meaning patient likely does not have. And we created a population with that, and you created a model, which I believe you're going to tell us a little bit about next.
That's right. Thank you for that intro, Carl. And just to quickly expand on this notion that Carl described of how we use this attestation-based way of thinking about TRD, one of the challenges, if we need to define a condition, is always saying, what do we believe is a good definition, right? Not just what can we write down, but what do we think is an actual, accurate reflection of what's happening in the clinical population. I'll say that, in the previous case we discussed with Gary, AAA is a fairly objective thing to diagnose by ultrasound. Every once in a while there's some variation, but once it's diagnosed, there's an ICD code for it that gets put in the patient's record, and now we know who these patients are. As you've pointed out here, there is no ICD code for treatment-resistant depression. Therefore, there's this proliferation of ways of defining it. But here we sort of went with the psychiatrist as the gold standard. We looked for attestations, as you described, like the one you can see highlighted on the screen, to just say, we're not going to pretend as the data people, not the clinicians, that we know what this is, but we'll at least sort of poll the audience of 600 psychiatrists or however many we were looking at to say, what do you think are the patients who meet this definition? When we do that, when we use that gold standard set, Phenome does what it always does, right? It says, I'm not going to worry about those other definitions. I'm going to find patients who look similar to those that the psychiatrists think have TRD. And again, similar kind of concept to in AAA. We do our statistical performance testing here. For those in the audience who may be familiar with this AUC metric, we use that to measure how good this profile is at distinguishing these patients from other patients with depression. I always say my quick sort of cliff notes on these are, 0.5 for one of these values is the same as the coin flip, so not very helpful at all. An AUC value of 1 would be a perfect model. The model gets it right every time. Don't believe those. They're fake if you see them. But when the value gets above 0.7, I begin to get interested. If it gets above 0.8, I get very interested. Here we got a 0.87. So what that's saying is the profile, this digital phenotypic profile that Phenome has isolated, is very high performing in saying within a depression population, here's the patients who match what the psychiatrists are pointing out as looking like TRD to them. But that's interesting from a statistical perspective. I think the more interesting results happen when we start comparing what this says relative to some of those other definitions you described, Carl. So I'll let you give the punchline here.
Right. So when we started out, we all had some hypothesis about what we might find. And I think the consensus was that there would be, in a Venn diagram, sort of concentric circles. That the data-driven definition, which is by any measure the simplest, would possibly be the biggest because it would be the easiest to meet in a real-world data set. Maybe the next biggest one would be patient finder, because it's sort of balancing that clinical attestation. It's using the whole medical record. And then the smallest would be the most constrained, which is the so-called regulatory definition. And when I was on my way to the APA in San Francisco, I had the pleasure of sharing a taxi ride with Maurizio Fava, who, for those who don't know, is one of the top 3 researchers in treatment-resistant depression in the world. And I told him about this study, and I asked him, Maurizio, what do you think, based on these 3 definitions, the overlap would be? And without hesitation, he said 40%. And I said, wow, that's really interesting you say that. The real answer is 1%. So when we looked at the data, we were all surprised to see that of the 73,000+ patients that we identified with all 3 definitions, that 61,000 of them, or 83%, only met one of the definitions. About 11,000, or 16%, met 2 of the definitions. And literally 776 patients out of the 73,000 met all 3, 1%. And that was a little surprising. But then going back to the sort of Venn diagram, well, what does that actually look like? And pardon the eye chart here, but I'll focus your attention to the right of the slide, where the 3 Ds are that data-driven definition. So that's the biggest population by far. And then you can see the RD is the regulatory definition, sort of straddling the fence to the right, and then the OM1 AI-driven patient finder definition, equally straddling the fence, but with very little overlap over the three. And this was a bit of a surprise finding. And as we talked about it on the panel, thinking about why, we kind of concluded that one of the drivers was time, right? The use of time in these definitions is actually quite different. So for the data-driven definition, we constrained it to 1 year, which means these are patients who are getting a lot of different medications very quickly, and it may be a very different population. People who maybe have side effects or have comorbid anxiety. We know that from the research, they did have higher levels of anxiety. A lot of churn in this population for any number of reasons, but certainly reasons that don't overlap with the other two definitions. The regulatory definition was not limited by time. And on average, it took over almost 3 years for patients to meet this definition, which means patients are languishing with depression over long periods of time without a lot of experimentation in terms of different medication modalities, at least. And then finally, the patient finder definition really used the entirety of the patient's journey. So we have 3 different time lenses, and this is where we landed, Joe.
That's right. And the thing that always strikes me about this one, Carl, is that I go back to that, some of the many conversations we've had from your perspective, practicing psychiatry about this, it when you see it function of TRD. And, the question I would ask, do you think that from what you've seen digging through these phenotypic profiles, that particularly those patients who are being found when we use our AI technology to highlight them, but are being missed otherwise, do you think those patients may match this notion of know it when you see it, but aren't getting caught or slipping through the cracks in other ways of defining the patients?
Yeah, I worry about the patients who are outside of that big bubble because they're likely to be the ones that, particularly in the patient finder model, where they're not meeting a standard definition, they're meeting a AI definition, but yet still have tremendous suffering. And as you know, when we looked at the PHQ-9 scores, the patient finder model was the only one that lined up with the clinician attestation in terms of having higher levels of severity. So the even bigger concern is that these are patients who are being missed, but also have very severe rates of and levels of major depressive disorder.
That's right. And if we can label them, treatment resistance does not mean that there don't exist other things to try, right?
Not only are there options today, but there are more coming in the pipeline. And I think a lot of the enthusiasm in the room at the APA, and I think for those of us in the field, is that we have a lot of so-called fast-acting novel mechanism antidepressants coming down the pipeline. The real question clinically is, who do we give them to? And until we get a consensus on this definition, I worry we're going to struggle in that area. And we need to, and I'll end with this, really create a sense of urgency in mental health. We know there's a crisis. Patients, have not only this chronic illness, but a deadly illness. As one of the panelists pointed out, a patient dies of suicide globally every 40 seconds. So this is a serious disease that needs to be treated.
Great. Well, once again, I'll say we could do a whole webinar just on this, but in the interest of time, we'll move on to our third and final case study. So we've talked about diagnosis, we've talked about treatment. Now we're going to talk about clinical trials. Really, I suppose, the technologies that can help us accelerate development of exactly those kinds of treatment Carl was just mentioning, the sort of next generation treatments that are both better work and better functioning and perhaps better targeted. We're going to switch to the area of dermatology here. And so I'm going to hand the mic over to my colleague, Dr. Weiss, to talk to us on the background of cutaneous lupus.
Great. Thanks, Joe. So from the heart to the brain to the most visible of all, the skin. So let's talk a little bit about cutaneous lupus, shall we? So really, when we think about lupus, specifically on the skin, the most noticeable aspect of that is what is called the butterfly rash or the Malon rash. And it's that cutaneous presentation that first alerts somebody to the possible notion that he or she may have lupus. Now, what's important is that lupus can sit specifically and only on the skin, or it can be more of a systemic issue affecting the joints and the kidneys. Now, cutaneous lupus is really a multifaceted disease, and we think about it in a number of different subtypes. So there is acute cutaneous lupus, there's subacute cutaneous lupus, and so those, as the definition would, or the name would say, one is a very fast onset in severe case, and one is a much slower onset as it's coming across. And then chronic cutaneous lupus is really what most people are suffering from when they have this disorder, and that gets divided into a number of different types. Again, where you have discoid lupus, lupus erythematosus profundus, chilblains, and then lupus tumidus. So again, we can't really think about cutaneous lupus as a single disease, but really more a disease that is autoimmune related and the many ways that it targets the skin. The two most common and most talked about from a therapeutic discovery standpoint are SCLA, or subacute cutaneous lupus, and discoid lupus. And as you can see from the photos on the screen, they are dramatically different in their clinical presentation. And so as we're going to talk about trying to understand how to identify patients who would be appropriate for a clinical trial with cutaneous lupus, you can imagine the complications just in looking at these two pictures and how different the presentation of this disease can be. So when we think about how to diagnose lupus, really most importantly is the physical exam. We do laboratory studies largely to rule out any systemic involvement. Histology, so a skin biopsy, can be very helpful as we look at whether there's an interface dermatitis within the skin structures. We will do antibody serology if there is evidence of systemic involvement to better classify the disease state. And then finally, in terms of the skin involvement, we would look at direct immunofluorescence for final confirmation that indeed this particular patient is suffering from a form of cutaneous lupus versus something else. And then treatment, as you can see, is not straightforward. Now, it's not to be necessarily as complicated as treatment-resistant depression, which has a 1% overlap. We sort of go around this map, and it reminds me of a Bugs Bunny cartoon and how you would try to figure out what you're going to do next. But clearly, when we think about cutaneous lupus, we want to treat it as we would treat all skin diseases, which is skin first, and whether we can use topical therapies. When topical treatments fail, we then want to identify some of the more classically used systemic agents, such as Plaquenil. And then finally, when those all fail, are there opportunities to leverage some of the newer agents that have been shown to be effective in systemic lupus for the skin? Or is the disease different enough where we need to identify very specific antibodies that would target cutaneous involvement that may or may not have been proven efficacious in systemic involvement? And so when we think about sort of the key takeaways from cutaneous lupus and really understanding where it sits, we know that the good majority of the individuals are either going to have discoid lupus or subacute cutaneous lupus. And what becomes important here is finding those right patients for clinical trials, understanding the diverse morphology of the disease on the skin. So with that, Joe's going to tell us how to solve that problem.
That's right. Thank you, Stefan. Yeah, the conclusion for the severely non-dermatologist, aka me, in this virtual room is that bad news is cutaneous lupus is intensely complicated. There's lots of nuance to diagnosis, lots of nuance to treatment. But the good news is there's at least the potential for development of lots of exciting therapies to help those patients, perhaps exploiting those differences to improve personalization. As any of us who have ever looked at a trial protocol for clinical trials are familiar with, a lot of the nuance I think that you described, Stefan, goes into inclusion and exclusion criteria. So we're looking for patients, obviously, who have a diagnosis of the condition we care about, but there may be many, many more complex characteristics where we want a certain presentation, we want a certain amount of prior treatment with one of the agents you mentioned, but naivete to another class of agents. We may want to exclude patients with certain comorbidities. There's just tremendous complexity. And as we all know, clinical trials struggle so mightily with enrollment and adherence, and ultimately that just delays the time to the development of new therapies. The reason we've highlighted this case is because phenome and digital phenotyping can be helpful here in the same way they've been helpful in other cases. But in the first instance, we said, let's use a diagnosis code to find the cohort we're looking for. In the second case, we said, let's take it up a level of complexity and use physician attestation as a way of identifying that group. Here, we're going to say, let's use the trial criteria, inclusion and exclusion criteria. Let's apply those as best as we can to the real world data set, and then ask Phenome to find the phenotypic profile of patients who look like those criteria. Now, if real world data were perfect and all data were perfect everywhere, you would say, well, let's just apply these criteria mechanistically. What do we need all this AI stuff for? It's just a filtering, right? Check the boxes in your Excel spreadsheet and you have the patients. We know that that isn't the reality, either in terms of data and in terms of real world clinical practice. We never have anywhere near enough perfect data to make an assessment at the individual level of whether a patient should be considered for enrollment or not. The reason using digital phenotyping can be quite powerful here is because we can get closer without needing perfect data. So when we've imported these criteria and said, based on them, find the corresponding digital phenotype, what we're really saying is make the best estimation with highly imperfect data to surface this patient's worth the dermatologist taking a closer look at, and then, if they decide it's appropriate, reaching out to the patient. That is a key accelerant in getting these patients, again, surfaced for consideration, which can help with enrollment. The output of all of this really has two exciting aspects. The first of those is sort of most obvious if we're talking about trying to improve clinical trial enrollment at known sites or known locations. We can say from a patient population, let's, from the lupus population, for example, let's bubble to the surface those patients who are most similar to those in X criteria for the particular trial we're considering. But there's also this advantage that trials aren't always looking where the patients are, right? And in particular, when we're looking out across the entirety of the country or even the world, there may be pools of patients who could be good fits, who may, for whatever reason, have the right profile within the broader universe of cutaneous lupus to match a particular trial. And this technology can say, look, some of those patients may be clustered in a location where they won't be able to access this trial. Perhaps it's useful to set up a site there as well. So, I think that this phenotyping starts off as sort of a most obvious use case in diagnosis, but the more we think about some of these expansions, the more and more use cases we can define with this. My question to you, Stefan, I know that clinicians, both Carl and Gary have mentioned, are very busy and they have a lot to worry about. And clinical trials aren't always at the top of their list because, patients are in their office because they need immediate help. It's hard to get attention paid to trials. Do you think that connecting patients today to medications in the future through this sort of personalization might help close that gap, specifically in dermatology?
No, I do. I think it's a great question. I mean, it really is the goal of what we're trying to do within dermatology. So when I started, we literally just had potions and lotions. And then over time, and advances in understanding the immune cascade allowed us to have a tremendous amount of systemic agents for psoriasis, and then atopic dermatitis, and now HS and alopecia areata and vitiligo. And cutaneous lupus is just the next along that cascade. So the more easily we can identify patients who would be appropriate candidates for these particular treatments, especially in diseases that are what I call semi-rare, the better the opportunity is to develop novel agents for those who are suffering from these conditions. And it really removes the barrier of bringing people in from community dermatology practices into clinical trials. And the fewer patients there are in the aggregate, the more they need to be identified within disparate community-based centers. And we can make that easier with things like digital phenotyping. So I really think this is going to be the way we're able to advocate for patients that have a lot of these more rare immunologic diseases. Cutaneous lupus is just the first, but I could envision bullous pemphigoid would be another one where this is going to be a tremendous benefit in bringing those patients in.
Excellent. All right. Well, hopefully everybody's hung on so far, because we've certainly packed a lot of content into most of the hour. But in the remaining time, just to transition to our conclusions, I'll just mention a couple overarching themes, and then we'll bring the entire panel on for some Q&A. But hopefully, this has been a somewhat clear and cogent presentation of both what digital phenotyping is and why, with a technology that can do it like Phenome, we can really impact different areas of medicine with different questions, patients at different points in their journeys, all by using sort of this same consistent approach. If we understand what the patient group is we're looking for, then we can use the technology to find the signaling information that helps us better pay attention to that group. This is really the heart of personalized medicine, taking those patterns at scale, translating them to the individual, and digital phenotyping has now been demonstrated through the work that we've been highlighting to be able to achieve that function. And finally, one last thing. Hopefully it's obvious by this collaboration. I'm certainly not a clinician. My clinician colleagues here have become AI experts, but we're not always so. One of the nice things that crosses all of these applications is we can have these conversations between the technical experts, the clinical experts, and patients themselves, because we're drawing on their histories in ways that we can study and understand and debate and compare with expert knowledge. And that is more critical than anything in medicine, as I'm sure everyone in the audience knows. We don't use sort of a cowboy approach to applications of technology. We need to make sure everybody can understand what's going on and see what's useful. We can begin our Q&A by discussing the results of the previous poll. And just to read out for everybody, what it looks like is, to recall, the question here was, have you already taken action to implement AI? 46% of respondents said they're currently using AI. That's quite high. Good for you. Maybe it's a very AI-friendly audience. 36% say that they're planning to use, and then 18% saying that they're not planning to use. I certainly am excited to see how much use there is already, and would just advise folks, as they think about applications, pick the ones that are going to demonstrate success quickly. That's how you build momentum for these applications. We have some responses to our second question here, and it looks like, of that cornucopia of options, the leader right now for the biggest barrier to implementing AI is an overly complex implementation process, followed closely by not knowing where to start, which I think is probably related. I live and breathe this stuff, but any of our panelists, I'd invite your commentary. Does it surprise you? If it doesn't surprise you, do you have any advice for folks who are thinking, this sounds great, but also really complicated, or I just don't know where to begin? Don't all jump at once. You may have to unmute yourselves manually.
I'll start. I think I've learned a lot working with you, Joe, and I have an expert in-house that helps me learn, and also we're applying it, which in my own experience is the best way to learn about anything. So I think there's going to be some hesitation in the field because of the complexity and the black box nature of it. I think clinicians, as a rule, as a group, like to know what's going on inside. That's part of the reason we went to medical school. So I'm not surprised that we're seeing some barriers. However, we live in a world where this technology is going to become, it already is, ubiquitous. It's going to become more used, and there'll be more use applications, and that will, I believe, change people's comfort levels.
Makes a lot of sense.
And again, I think from my standpoint within dermatology, it's really shown the opportunity to, again, find the patients who are not otherwise found. And that's really what's most important. There's a number of very common skin conditions and much, much more uncommon ones. And those are the individuals who tend to get misdiagnosed because it's dermatology, everything looks like a red itchy rash. But those red itchy rashes are very different. and understanding those nuances is what allows us to pick the right treatment. And so by using AI to, as you started at the onset, recognize patterns, that's the key. And to find those patterns and identify those patients allows us to get the right drug to the right patient at the right time. And that's really where AI is going to drive the field for skin disease.
Makes a lot of sense. In the few minutes we have left, let's jump right into the queue of the Q&A and see what the audience has asked. So first question that I think is quite interesting. Do you ever see AI applications being approved and subsequently reimbursed? My quick hit is yes, AI applications are already being approved and will continue to be improved. They will have to be reimbursed eventually, because this is one of those things where 30 years from now, this is going to be second nature for us when we interact with healthcare. It may seem distant now, but the payment for these kinds of things will become part of integrated care delivery, in my opinion. But any panelists, please contribute.
Yeah, I'll jump in. I was reading recently the FDA actually released new guidelines in the last fall around machine learning, and that actually is pretty novel, right? Because if you think about the FDA, they like molecules that are static and devices that don't change. And the thing about AI is it changes over time. Machine learning learns. So I think what we're seeing is FDA moving in the right direction to try to keep up with these technologies, number one. And then number two, to the earlier point about building confidence among clinicians, I think having that imprimatur of FDA approval and the rigor that comes with that will help with adoption rates and ultimately reimbursement. That's my opinion.
Got it. Another question, just in the interest of time. Do we have any specific applications for assisting diagnosis in the area of rare disease? We didn't really talk about this, but we certainly have used this kind of technology with rare disease, an area where patients commonly languish for long periods of time without diagnosis. And Stefan, you were just mentioning there exists this long tail of dermatologic diseases that are different to you and not obvious when the patient first goes into a non-specialist. I do think that there are specific applications of this technology that can help there. I am always reminded that most physicians don't see most kind of patients more than a couple times in their career, right? Because they've specialized in their area and patients come through, but we just can't pile all possible expertise into every clinician. That's where some of these tools can help. One other question we've gotten here, the question is specifically about our AAA work that Gary, you and I walked through. The question is, does Phenome decompose the model to a limited number of risk factors for explainability? I can answer technically, not necessarily. We can sort of extract specific risk factors. But Gary, or any of our other clinicians, could you speak to how your experience has been with sort of the explainability and interpretability of this stuff?
Can you hear me, Joe?
Yes.
Okay. So I actually think it's been fascinating. In medical school, we get taught that this is what a patient looks like and not all the different flavors and variations. And it's only as we gain clinical experience that we say, okay, they don't all look like that. Even so, we're still limited in what we'll be looking for. And it was very helpful, certainly for AAA and some of the other rare conditions that we've looked at, to see these signals that come up that say, oh, wow, hadn't thought about that, never been taught about it, but it actually does make sense. So I think it helps. Carl had mentioned about the black box, that it helps by showing some of these things and not just like, oh, it's hypertension and smoking, all the things we already know, to actually show some of the things that we don't know, to me will make it much more acceptable that it is telling us more than what we think we already know.
I agree. And I think also, Joe, you taught me, and this is important for people to understand, is you can't take these models and turn them into lists. That actually is a mistake, because it will greatly constrain, well, you end up with a textbook and all the limitations of a textbook. So I think getting people to understand that these features are different ways in which patients with the pattern or signature can be identified is a very different way of thinking about diseases and diagnosis and identification.
Makes a lot of sense. I'm glad that you've absorbed my line that AI models are not checklists. If they were, we wouldn't need the AI. All right, so we're just about at the top of the hour. I want to thank everybody for your attention, and hopefully you got something useful out of this. Thank you, to my colleagues as well. It's always great to do these kinds of collaborations. And I'll turn it back over to Sydney to close us out.
Thank you so much, everybody. Okay. In closing, we hope you enjoyed this HealthEconomics.com webinar sponsored by OM1, and I hope you enjoy the rest of your day.